royceb.co as well. Today's Sweet Auburn Stories guest is Dr. Frank Richards Jr., and he is a trailblazer indeed. If you haven't heard about him, you should definitely know about Frank Richards Jr. Dr. Frank Richards Jr. is the Senior Advisor of Health Programs to the Carter Center. He focuses on international programs working on parasitic diseases that affect impoverished people in Africa and Latin America. He recently stepped down as the Director of Elimination Programs on river blindness, lymphatic filariasis, and others, which over a 15-year period, he's helped ministries of health in 11 countries provide more than 500 million treatments to treat and provide debilitating diseases. Additionally, under his leadership, the center helped governments in Nigeria and Ethiopia to distribute over 18 million bed nets to prevent malaria, reducing infection in the focus areas by 50% and 90% respectively. In layman's terms, he's really done a lot to help decrease the spread of malaria. Dr. Richards came to the Carter Center from the U.S. Centers for Disease Control and Prevention, the CDC, where he spent 23 years in the Division of Parasitic Diseases and Malaria. Richards earned a Bachelor's of Arts degree from Williams College and his medical degree from Cornell University, and he's garnered numerous awards throughout his career. He's published over 240 articles, chapters, and letters about his work, and chairs international committees focused on the elimination of malaria and river blindness. Whew! Few things. So he has done a lot. So without further ado, I'd like to bring up Dr. Frank Richards Jr.
Hey, Royce, how are you?
How are you? How's it going?
Happy post-Thanksgiving. I have one more day of leftovers. So
yeah, man. I told you, like I said, I'm a 1.5. What are you?
I had a burger last night, but I think it was more my wife insisted on it.
I had a burger too.
I'm back to the turkey right after this session. That's what I'll be doing.
Okay. So welcome, Dr. Richards. I'm gonna jump right in. We normally play a game called Wordplay here, which is a quick rapid fire word game. But because we rarely have someone in the medical field, I thought we'd change the game up a little bit because I want to know a little bit more. So
do I win any money?
You win. No, you don't. I'm just gonna shoot you straight. You don't. You don't win any money, but you win the adoration and affection of the many people watching the video.
Okay. All right.
Okay. All right. So this game is called Your 2 Cents. So essentially what I do is I hold up a question or a word, and I'd like to know more than one word, but your 2 cents on the topic.
Okay.
So professional we are here. Yes, here we go. All right.
Of course, I haven't seen any of these before. So.
No. We should make that clear. So right. I'm going to start with the first one. Mosquitoes. Do mosquitoes have a purpose on this planet?
Yes, they feed a lot of birds.
Mosquitoes feed a lot of birds.
They're very important in the ecosystem. So we want mosquitoes, but we don't want mosquitoes to transmit nasty diseases like malaria.
Okay, that's good to know because I've always questioned. What about flies?
Flies are nasty too, but they don't tend to bite so much.
Do they have a place in the ecosystem?
Yeah, everything. Yeah, everything has a place. Even viruses have a place. Believe it or not.
Okay. Good to know.
Yeah.
Okay, my next one. The CDC is in Atlanta.
Right.
How is that the case when the most fun parties are also happening right now in Atlanta during a pandemic?
Can you say that again? Because you broke up a little bit. Sorry.
Sure thing. So the CDC is in Atlanta, but also some of the livest parties in the country are also happening in Atlanta right now during a global pandemic. How is this the case?
People aren't listening to CDC.
Okay, that is as simple as that.
Well, yeah, and it's also because unfortunately a big effort has gone into telling people not to listen to CDC, which is very distressing for someone who worked for CDC for 23 years. But yeah,
got it.
Re-empower CDC. That's what I
Re-empower CDC. Okay, I like that. I like that. All right. All right. This is my next one. Let's see. Broke and healthy. Why is it so hard to get affordable health care in this country?
Well, yeah, so that's broke does not equal healthy.
Does not equal healthy.
That's how I read that. And, I think the problem is that for some reason, we in this country don't believe that health is a human right. At the Carter Center, we believe that. And a lot of countries around the world believe that. And maybe one day when the United States government believes that and the United States people believe that, you can be healthy without being broke, or you can be healthy without being rich. How about that?
Right. Yeah, I would love that. All right, the next one. Passion or practical? So should you do what you're passionate about or what's practical?
I think you should do what you're passionate about, and always have a fallback position.
Okay.
Always have a practical fallback position in case your passion doesn't get you to where you want to go, but give yourself a chance to live your passion. That's what I say.
I agree. All right. Do you think that we have more than 100 years left on this planet?
Wow, that's an interesting one. I do think we have more than 100 years left. My big question is, do we have more than 200 years left?
Do you think we have more than 200 years left?
I think that is questionable if we have another 200 years, especially from the perspective of global warming, is what I would say. But I would also say from our experience right now with the pandemic, if you are talking about human beings on Earth, then I think we need to learn from this experience, because guess what? COVID isn't as lethal as something else could be.
This is true. Okay, understandable.
Lethal, but
my last question.
Other things we know. So
yeah.
We need to learn our lesson.
Learn our lesson. Okay. And this one will be given without context. East side or west side?
Well, I went to medical school in New York City on the east side. So while everybody says everything's happening on the west side of New York City, I enjoyed my time on 70th and York.
So you're going to go with the east side?
I'm going with the east side because that's my neighborhood.
Okay. You went with the east side. I'm not going to answer, but I might have a preference for the west side.
That's okay.
All right. That is your 2 cents. Thank you so much, Dr. Frank Richards, for playing your 2 cents. So we just got your quick thoughts on a few things. And I read your bio a little earlier, so I have a few things to ask you, and I'm so honored to have you here first. I'm going to drink a little tea. All right. So, Dr. Richards, you are a native of St. Louis, and your father was a well-decorated surgeon there. But you told me a little bit of a story about how he couldn't practice at the hospital across the street because he was Black.
Right.
How were you impacted by this as a kid?
Well, I think it's important to recognize when I was coming up. So I was born in 1954. I'm 66. And I can remember a lot of the seminal things that occurred pretty vividly, from Kennedy being shot to Martin Luther King and Bobby Kennedy being shot, and Malcolm X, all of those sorts of assassinations.
Right.
But I also grew up in a time of segregation, at least in St. Louis, certainly up until the 8th grade. So I was raised in a black neighborhood, went to black schools, black church. My father, an African-American physician, could only practice in certain hospitals. And what's really interesting is that even though we lived in an African-American neighborhood, the hospital right outside of our front door was a segregated hospital that didn't allow black patients and didn't allow black physicians.
Right.
And so, I've reflected on it a lot, imagining my father, who was a surgeon, a fellow of the American Academy of or College of Surgeons, coming out the door every day and looking across the street at a place he could not go into.
Mm-hmm.
I mean, not even as a physician, he couldn't go into as a person, as a human being.
Oh, wow. Right.
And I think, that's one of many examples from places that we have to go, in particular to vacations or restaurants we couldn't go, etc. It left an indelible mark. For sure.
Yeah. I mean, you see your dad, who is, a scion of the community, who's doing great things for medicine, who's recognized nationally, perhaps even internationally, and he can't even go into the hospital to work. That's pretty impactful to me. And you even talked about how you and your sister helped integrate the high schools here in St. Louis. And, we've talked to some folks that have integrated places before. We've talked to a number of people in a generation even above yourself or that are a little older than yourself. And I'm always eager to understand how integration actually worked, because when I think about even some of the things that you're doing on such a large scale, which is ridding the world of diseases, you have to think about actual process at scale. And I think about how this was done or not done in America. So I wonder, you integrating high schools in St. Louis as a youth, what was that like? Were they just all right, Frank, you're going to the white high school?
Well, actually, it was my integration experience was started off in the 7th and 8th grade, and before I got to high school. And I was still living in a black neighborhood, but in those days, we're talking 66, 67, opportunities were beginning to open up to integrate or to go to previously all white schools.
Right.
And so, it was interesting because my particular story, being light skinned, was in the all black school. I was a white boy. So then I go to an all white school, saying, "Oh, okay, well, this will be fine." And I wasn't there for 2 days before I was called a nigger. So to me, it really left a mark on my understanding of how contextual, if you will, the definition of race was or is to this day. Back in those days, it was very binary. We live in a much more brown community, a much more rainbow society now.
Right.
It was, you're black or white, and if you're not black or white, what are you? And the what are you for me was a big part of my sister and my experience in that process.
Yeah.
So that's how I would explain that. When we went to high school, we actually moved to a new neighborhood. So then we were involved in integrating a neighborhood as well as integrating the high schools. And the very interesting story there was the fact that as pioneers, if you will, going to these areas, there were covenants in these neighborhoods called sundowner clauses.
Okay. So this is important. I wonder if this is very similar. If anybody watches Lovecraft Country, they mentioned that this town was a sundown town. I wonder if it's about what you're about to say.
Well, we moved into a neighborhood that had a sundowner covenant. And so the only way that we could move in would be for the other neighbors to sign off on a change in the covenant that we could be there. So
what if the sun down? What was related to the sun though?
Oh, because if you're African American, you could be there working during the day.
Got it. But you
And maybe
can't be there after the sun goes down.
you could also, if you were a live-in maid or help, you could stay inside. But the point on sundown is you couldn't be on the street after sundown if you were African American.
And you remember this very vividly.
I remember going around from door to door with my parents and my sister.
Right.
Saying we're the Richards, we're moving in, but the word in those days was we're Negroes and we can't be here.
Right.
Unless the covenant's changed, will you sign this piece of paper? And it was very deep. But the very positive thing that I'll tell you, Royce, was that the neighbors, by and large, were incensed that we should have to do that. And I remember people saying it was winter or cold. They said, "Let me get my coat. We're coming with you." By the time we had gotten
to each door,
yeah, by the time we had gotten around the neighborhood, it was like a cul-de-sac, a court.
Right.
It was like a posse, and basically the other neighbors were saying, "We know you're going to sign this, right?" To everybody else.
Oh wow!
And it was a very positive experience.
Wow. So you had
an extremely positive experience for me.
Nice. So you had allies in the community that actually not only were like vocal allies, but went with you to the next home.
Totally spontaneous.
Wow.
This wasn't organized. This was totally spontaneous. And it's interesting because the city that we moved to was called University City. It's a suburb of St. Louis.
Right.
It's called University City because Washington University is there. A progressive community of having a large university there.
Mm-hmm.
A large percentage of the population was Jewish. A large percentage of the court on the neighborhood were Jewish, and so, but not everybody. But it was a rabbi lived on the street, a Methodist priest lived on the street, a Presbyterian priest lived there. A minister lived on the street.
Yeah.
So, it was that group of people that are like, we cannot believe you're having to do this.
Right.
Come on, Dr. Richards, we're going around and fixing this.
Oh, so wow.
That's my very positive story from that perspective that I have to offer.
That's beautiful. I think that that example of allyship during that time is really a shining example of what we need. Yeah, we needed to go to go to the next level to get here, and then what we're seeing with allies today with Black Lives Matter or any movement of some sort of people that are being discriminated against or what have you. I think you have to have those allies that are not only willing to be vocal but willing to actually fight with you and encourage others to do the same.
I think that's a good. Just one quick additional story related to my father.
Yeah.
If you can imagine it. So he's a surgeon, and he wasn't internationally famous, but he was certainly famous within the community.
Got it.
He was one of the first to integrate some of the hospital staffs, like the hospital that I told you in the early days didn't have African Americans. So if you can imagine, all the surgeons sitting around after between their operations and their scrubs and their masks are hanging around their neck.
Right.
And they're chatting. My dad's there and some white surgeons, and they're talking about their insurance. And so they say to him, "Frank, what insurance do you have?" And he said, "Are you all kidding? Who's going to insure me? They don't insure Black people." Wow. And they were incensed.
Wow.
They called their insurance companies and told them they had a common insurance that they were going to leave their insurance company if they didn't insure my dad.
Wow.
That's so just a couple of examples to get back to my point, or the point you were making, that we need coalitions in this time.
Yeah.
And these were examples of white people oblivious to systematic racism. They're oblivious to it.
Yeah.
They weren't racist, but the system was racist. And having those blinders taken off resulted in them, honestly trying to do something, and indeed doing something to help. And those are the opportunities we need to think about now, in my opinion.
That's important. So you integrated high schools. After your high school, you headed to Williams College in Massachusetts for chemistry. You started to follow in your father's footsteps in terms of like actually starting to get into the math and sciences on a post high school level. Then you went to Cornell in New York City for medicine. And something happened in your fourth year that led you to focus on infectious diseases, and it was when you were in Bahia. Can you tell me a little bit about that experience?
Well, sure. Well, actually, it was during my second year when a lecture was given. It was in 1977 on tropical diseases, on malaria and a condition called schistosomiasis that I still work on today.
Schistosomiasis, that's how you pronounce it?
Yeah, that's how you pronounce it. Yep.
Schistosomiasis. Okay.
And I was just captivated. That was one of those times that was just, for want of a better word, an aha moment. It was a defining moment for me in that I really sort of had a light bulb go off in terms of this is what I want to do, and which was tropical medicine, tropical infectious disease.
Right.
Working on conditions that you don't find in the United States for the most part.
Yeah.
So I sealed that that idea that was what I was going to do by taking the opportunity to spend half of my fourth year in 1979 in Bahia, Brazil, sort of out in the wilds, working on another disease transmitted by, in this case, flies, sand flies, called leishmaniasis. And after that, I was just sure that was what I was going to do. That was there was no turning back after that.
Right. So second year, you heard the lecture. Something went off in your brain that unlocked a passion in your practical decision, and you continued to kind of follow that passion, still within the safety of your practicality of medicine. And then you kind of blossomed into that as you went on, right?
Right. My father, a surgeon, wanted me to go into surgery and come back and practice with him.
Right.
So he was fairly distressed at this idea, and particularly an idea of, I'm going to travel the world working on infectious diseases that only affect the poorest of the poor in Africa and Latin America and things like that. And he thought that was crazily utopian, and that I needed to sort of get over that.
Yeah.
So
practical.
that's how we came back on the little flashcards you were showing on passion versus practicality. And he was the practicality side, which made me pretty sure that I needed to have a fallback position. So I made sure that I finished my studies in pediatrics and got certified there, so that if this didn't work out, I could always hang up, my name outside of a door somewhere and practice there.
Right.
But I wasn't going all the way to become a surgeon. I didn't like staring at wounds all day, so that was not something for me.
Right. So you within the bounds of your practical decision, you started to explore your passion, which is exciting. And then your father wasn't really too sure about it. And we know a lot of times, like when our parents aren't sure about something, and it brings us to question it, but we always have to kind of find our way to our passion somewhere. So then you started to do pediatrics, and you go to USC. And you're studying out there, you're doing pediatrics there. And then how do you end up in Atlanta? So you've been Northeast with Cornell, you've been out West with USC, you've been in Brazil, you've been in Massachusetts, and you end up here.
Right. Well, automatically you've discovered, one of my passions, which is to travel and to go to different places. So certainly one of the reasons I was interested in tropical medicine was because, if I could spend my professional career traveling to different places, then I would be a very content man. So you've already traced, Midwest to East Coast to Los Angeles. But I had been advised when I spoke to different folks about what I wanted to do that it sounded like my best bet to have the kind of career I was envisioning. And believe me, this is not a career that the stepping stones are very clearly laid out. Like if you want to be a surgeon, it's like you do A, B, C, and D. If you want to be, a pediatrician, you do A, B, C, and D.
Right.
In this case, what I'm describing, people are saying, like my dad, well, maybe you haven't really decided what you want to be yet when you grow up.
Right.
So, but when I spoke to people who took me seriously, and a lot of people did not take me seriously.
Really?
Those people, I mean, I can remember interviews that I would take, to get into my residency program in pediatrics. And when they asked me what I wanted to do, and I said I wanted to do tropical medicine and infectious disease, one person said, "Oh, okay, now that we've established that you don't know what you want to do." Well, needless to say, I didn't go to that program. The program I went to was when I went there and mentioned in Los Angeles, this is what I wanted to do. They went bonkers on how excited they were. And they said, look, we have all sorts of patients who come from Mexico. They've got, malaria and these different, tropical infections. And you'll get to see some things while you're doing a classic, pediatric training. And we'll make sure we call you to see all these cases. And I said, this is where I'm going. So anyway, the advice that I got was you should go to the Centers for Disease Control. Because at the Centers for Disease Control, not only do they do work in the United States, but they do work globally. And so you should be able to find an opportunity to explore your passion at CDC.
Was it easy?
No, I mean, I originally got in the wait list of the program at the CDC called the Epidemic Intelligence Service, the EIS program, which is the disease detectives. And they take about 100, 120 folks every year for a 2-year training period. And after that, if they don't have a job for you, then you're back on the street. So I applied to the program. I didn't get accepted immediately, but I got a letter in May, about a month before I was through with my pediatric residency, saying a spot opened up, or we got some extra money, and we want to know if you still want to come to Atlanta. And I said, yep. And I packed up my 1972 Volkswagen Beetle and drove back across the desert, heading south to Atlanta.
Got it. So
arrived right here in 1982.
Okay.
June.
Okay. 1982 Atlanta. So we're talking, this is before underground Atlanta. This is like, was it Freaknik time? Freaknik was happening, or no, not yet.
No, I don't think Freaknik started happening. Wasn't Freaknik like 91, 92?
Yeah, early 90s. Okay, so you weren't.
I even still have a Freaknik hat, but unfortunately it's red. It looks like a MAGA hat, so I'm afraid to wear it.
So this is good to know. Important questions. Were you, Dr. Richards, one of the Freaknik guys who had the girls on top of their car around Greenbrier Mall?
No, by then I got married in 87, and by then I was not Freaknicking.
just there for the collateral. I understand. That's good to know. So you came to Atlanta. You started with the CDC after you were waitlisted, and then they brought you in. They had a
quick idea. When I was looking around Atlanta for apartments, I looked. 285 was there. The big 85 route was still being constructed. So what's now a sort of an access road is the old 85 if you're coming out of downtown. And Tree Industrial Road was a bunch of mud. They were still creating it.
Oh wow!
So that's what was going. That's what Atlanta looked like when I came to town.
totally different than it looks now. So you've seen the changing face of the city. Totally.
Yeah.
And so you ended up spending 23 years at the CDC, and most of your work was on parasitic diseases and malaria, which is a preventable disease, where just based on my research, and you can correct me if I'm wrong if these facts are outdated, but 92% of the cases are in Africa, is what I was reading. And, you know, I think about that, and I think about a disease like malaria, and I'm like, wow, 92% are all on one continent, and I'm sure those heat zones are very strong.
And the other condition I work on, river blindness, is 99% in Africa. So these work on principally affect, the mother continent.
Right, and both preventable diseases, right?
Yep.
So we're talking preventable things that obviously can, are not natural causes, I guess, is like the layman's term, in like a cancer or something which is not a preventable disease, right? And when you spent time at the CDC, which is essentially a government organization that does things domestically and internationally, what did you discover during your tenure there about preventable disease and money and the relation between the two?
Well, I was extremely interested, and this goes all the way back to medical school.
Yeah.
One of the things that really struck me about these conditions was that nobody really needed to, they were gone from the United States, and nobody really needed to suffer from these conditions other than from the fact that they were resource poor, that they had no money. They basically didn't even participate in a money economy, if you will. They were subsistence farmers, living in conditions that exposed them to mosquito bites, fly bites. They had poor nutrition, which results in your being more likely to succumb from these infections. Lived in houses that had no screens, dirt floors. All of these things are poverty related. And I remember once, in the 23 years I spent in Guatemala, 5 of them at CDC, I should say, 5 of them I spent in Guatemala, working in very, very poor communities on malaria and river blindness. And I remember one time I was doing a survey in the highlands of Guatemala, asking people what diseases affected their communities, trying to scale where people in their own concept of illness rated different things.
And are you doing this through an interpreter, or is it because you?
Well, I by that time I was speaking Spanish. I worked with a Spanish team, so I learned Spanish, and the interview was being conducted in Spanish. Although a lot of people did not speak Spanish. A lot of these folks were, indigenous people, Mayan Indians, who especially the women didn't speak much Spanish.
Oh wow! So they were that poor, I guess, or that removed from society to where they didn't even speak Spanish.
Yeah, illiterate communities. Yeah.
Wow.
And but I was, there was one old man that really, in his answer to these interviews, really struck me. And we had a group of trained interviewers. I'm sitting there listening.
Yeah.
And when he was asked the question, what is the worst disease in this community? His response was, imagine a poverty you can't escape. So his response to a disease was poverty.
Right. Right.
And it struck me like right here. And so the answer to your question is his answer, and that this is poverty that can't be escaped. And what comes with poverty that can't be escaped are these conditions that we're talking about today. And yeah.
So really quickly, what is the reason why and this may be a very, very, you may see this as a very simple or basic question, but why are these countries, these nations so incredibly poor? Are there any, I'm sure that, are their leaders rich? Or is it just an entire community across the board, top to bottom, of people that are so
tremendous disparities. I mean,
okay,
extremely rich people,
mm-hmm.
A relatively small middle class,
mm-hmm.
Sort of a pyramid, and at the bottom are folks, especially the indigenous people that make up, in the case of Guatemala, 60% of people would be pure Mayan blood.
Right.
At the very bottom, working in agricultural systems that are largely, one could call it, indentured servitude to a certain extent. Right. And it really is hard, isn't it, to try and explain why disparities to that degree ought to exist.
Anything?
If you talk about it, we're seeing it now. The commercials come on TV in Georgia that you're a socialist,
right?
And I don't think that there's any problem with having rich people. I just think there's a problem with having super rich people and super poor people. I mean, there's got to be some sort of way to level those sorts of things out so that basic human needs, shelter, food, health, ability to make a living wage are met.
Yeah. So during your time in Guatemala, and the reason I'm asking this is because I'm a big believer that perspective, garnering perspective and gaining perspective.
Let me answer this phone real quick. Sorry.
Yeah. She's important.
Okay, I'm back.
Okay.
I just picked up and hung up. I may have to pick up and hang up again.
You ripped it out the wall?
No, man. I just picked up.
Okay. So my question is, you were in Guatemala for 5 years, and one of the most beautiful things about life, I think, as someone who travels myself and someone that's spent a long period of time abroad, is perspective. I think when you are dropped into a place where you have to live amongst the community, gaining perspective is one of the most valuable things that you can put into your life hat of your toolkit. Yeah. So I'm sure, living in Guatemala, seeing the incredible amount of poverty, you gained a lot of things. How was your perspective on poverty altered? Because I know how we treat people that are poor here in this nation, and it's not nice at all. And we often think that they did something to get there. And so they're, because we're a nation of pick yourself up by your bootstraps. And if you're poor, it's a reason you're poor. And, but it's a cyclical thing that, to your point, can't be escaped. And oftentimes. So your perspective forever shifted from living in Guatemala, and then, what biases did you have that were changed?
Well, the truth of the matter is that very early on, my parents liked to travel a lot. Mm-hmm. So as I was growing up, we had the opportunity to go to Mexico. We had the opportunity to go to numerous islands in the Caribbean. And, so you started to see some of those kinds of things about the disparities and recognize outside of the United States. I mean, it's bad in the United States, but, folks living in, log cabins or, under 10 roofs, that kind of thing. And that really attracted me from a young age. And when I was in college, I should say in high school, and then on into college, I was really sort of into the idea of the need for social change and equity related to people who were just impoverished, and the idea of human rights and social justice, etc., was all around me in growing up. I think that was one of the reasons the lecture in medical school struck me so deeply, because it gave me that opportunity to explore not just an interest in travel, but an interest in justice.
Right.
So Brazil, again, was an intensive experience in an extremely poor part of that country. And then Guatemala, therefore, wasn't a total shock to me in the sense of this is the first time I've been seeing people living like this. But it did give me the opportunity finally to have a 5-year experience of really working and living in the field to get my arms around it in a different way than I had before.
Yeah.
Another great thing about travel for me is learning languages. I enjoy languages. I have worked in Spanish and French, and that's another angle of the explosion of the mind that you're talking about, that you gather from these kinds of experience. And I hope that people in the audience, if they haven't had those kinds of experiences, will try and find a way to do it, or try and find a way for your kids to have that opportunity, because there's nothing like the experience that you get from that life-changing opportunity.
Mm-hmm. Yeah. And perspective. And so one thing, to kind of echo you, is that when I've traveled, especially when I've traveled alone and I've gotten a chance to really integrate myself into different cultures.
You told me you went backpacking. You've been backpacking around.
I did a little bit of that. I did a little bit of backpacking. And I had very different experiences to, very, very, treated very well and lived very similarly, actually much better than I live here in America. And then I've had, and then in that same trip, I had an experience, had various experiences where I was able to travel alongside people in the mountains of Vietnam. But I've also gone to Haiti, and I've seen where there's extreme poverty. And, I'm so affected by it, because it really does affect every aspect of your life. And it causes, bias it causes personal bias, because like I said, in America, the way we view people that are poor is just abhorrible. Yeah. And
it's your fault. If you're poor, it's your fault. That's
exactly. If you're poor,
the American way.
Yeah. And so I look at this, and when I see that data shows that, there is a medical bias against people of color. I mean, we're seeing this now with what's happening with COVID-19. People are 2 to 4 times more likely to die from COVID-19 related causes. We see this with women of color that are pregnant, and we see the high mortality rates of the women and their fetus. So, there have been studies that have shown that there is bias in the medical field against people of color. How do you, in your daily role, combat that bias? Although you may not be practicing, how are you really working to combat medical bias? And really in an industry that should not have a bias, but, that's the world.
Well, as you say, I'm a bit removed from that. I don't practice. I haven't practiced since 2005. I did an infectious disease fellowship at Emory, and have been, on faculty at Emory University and at Eggleston Hospital for some time. But I think that the COVID-19 epidemic has really taken a scab off of the wound, and showed us how it's bleeding. And from my perspective, and this is sort of going back to your 2-minute drill or whatever that was, when you showed CDC, I really am looking forward to the new administration.
Yeah.
now coming and grappling with COVID-19 and the disparities that we're seeing in the increased toll on African Americans, Indigenous Americans, Latinos, and understanding that there's a big societal and economic element to that in terms of how the system proportions healthcare and how that is really showing itself through COVID.
Yeah.
I want to see that grappled with, and I want to see, in particular, the African American professional staff at CDC engaged in a way that they are contributing from their unique perspectives on how to grapple with this and see CDC as such an important role, such an important institution here in Atlanta, step up again and be empowered, as I said, to improve in many ways, not just the COVID response. Hopefully, with vaccination, we'll be able to turn the corner in the next year.
Yeah.
But use this in a host of other things, and that is what I'm hoping for.
Yeah, like, is there a, hey, Black people are affected task force team at the CDC? Is there like a, hey, everybody, people of color are really hurting?
Well, I'm pretty dismayed. I mean, I retired from CDC in 2005, but I'm pretty dismayed to have seen in the Washington Post and heard on NPR reporting that the African American professional community and being backed up by other persons of color, Latinos and Asians and others at CDC,
right.
With some dismay about the voice as well as the structure for promotion and leadership and retention at that institution. And I have no doubt that the current administration wouldn't pay too much attention to that.
Right.
But the incoming administration ought to. I'm hopeful, and I want to say basically confident that will happen.
Yeah.
And I do think that because the African American professionals spoke up and are on the radar screen before all of this change in administration, that they are in a good position to be able to hear some of their concerns met. Because you can't strengthen CDC without strengthening the COVID response, and
right.
You can't strengthen the COVID response without strengthening the response to inequities, and you can't strengthen the response to inequities without dealing with minorities representation within CDC. And so I'm hoping we have a personal, what should I say, a perfect storm, if you will, in making a change in our important institution here in Atlanta.
Right. And, you've been at the Carter Center now for a number of years. And in the most layman terms, the Carter Center focuses on two things. That's health and peace.
Right.
And I didn't really think about it until our conversation about how much they affect each other, right? Health and peace are actually quite symbiotic, and one directly affects the other. How have you seen this in your work?
Well, it's very interesting. President Carter and Mrs. Carter established the Carter Center to recreate, if you will, their experience at Camp David. And if you recall, the peace that was established between Israel and Egypt, Begin and Sadat, was a high point during President Carter's presidency, and the ability to bring people together for peaceful resolution of difficult problems was a major endeavor. Related to that was election monitoring, human rights, equity, And what was discovered early on, especially since the first CEO of the Carter Center was the former CDC director, Dr. William Fagey, who I think went a long way with convincing President Carter that if you're dealing with human rights, then you should think of health as a human right. And there's so many things that can be done to improve the health of very poor people. And Carter is very passionate about the poor in very simple ways that can improve people's lives and livelihood. And so that became part of the fabric of the early Carter Center. And now there are really two arms of the Carter Center, two pillars: the health programs and the peace programs.
Yeah. And they directly affect each other. And you worked on some things. I mean, you've specifically worked on a couple of initiatives that have directly impacted peace through health, right?
Right. So the idea is peace for health and health for peace. And it's sort of not hard to understand peace for health. I mean, if you have war, it's not good for your health.
Right.
I mean, even if you're not getting shot at, civilian populations are displaced, they're starving, they become refugees. So obviously, peace is good for your health. But the other side, how is health good for peace, is the other interesting angle to this. And in our programs, we've discovered that you can use peace, the need, I should say the need for health and a health program to bring warring parties together to say, look, there ought to be at least periodic ceasefires. There ought to be ways that relief can get into areas to help people whose health is being affected. And so the need for health has led to ceasefires. And President Carter has done that on a number of occasions. And I had the opportunity in 1995 to go into South Sudan as part of a medical outreach during what was called the guinea worm ceasefire. So the Carter Center is very much, its primary health program is the eradication of a condition that we call guinea worm. It's a terrible worm. It's 1 meter long, comes out of your leg, very crippling. And this has been our flagship effort. And President Carter negotiated a ceasefire amongst these warring parties on the north and south of Sudan in 1995, specifically to fight guinea worm, as well as to launch river blindness control programs, immunizations, and polio eradication. So that's an example of how the need for peace, the need for health, can get warring parties to, at least for a period of time, talk about stopping shooting.
That's pretty powerful that someone and an organization that's focused on that can really, like, outside of the core government function, can actually create peace in a nation through its efforts with health. And that's incredibly powerful, I think, how you can, the linkage between health and peace and peace and health.
Yeah.
So, you know, I think often about how 9/11 changed our world forever and how we traveled domestically, internationally. And that was only one city in one state in one country. How do you think, make some predictions for me on how you think COVID-19 will change our world in whatever capacity? This is every country, every city, every place, every corner of this planet, pretty much.
Right.
You know, and I think about, you know, with 9/11, now I can't bring my like shampoo or my like, you know, big bottle of lotion, my Jergens into the airport, you know, and take it across security because of something that was a very isolated incident when you think about it.
Yes.
We're still feeling the effects. So will I have to wear a mask forever or no?
Well, I think you're going to have to wear a mask for a long time, you know, until we figure out how the vaccination programs are going to work. These are still going to be challenging times. We have a very big challenge as well with communication. Already, a lot of people feel as though COVID-19 is a hoax. It's amazing to hear some of the doctors reporting now that some of the red states are having big caseloads that
Yeah.
folks, I mean, can you imagine folks are still coming in and saying, while they're lying in bed getting oxygen and about to be intubated, that this can't be COVID-19. That's a hoax. This must be something else. That is the testimony of a lot of healthcare professionals. And let me tell you, those are real heroes. My kudos and my congratulations and my prayers and best wishes go to folks who must be totally exhausted at this point and wondering how the overall population could be making so light of the COVID-19 pandemic. And it speaks to the power of communication and especially the fragmentation of the U.S. population and this battle against science. So, what can we hope for coming out of this is what you're sort of asking.
Yeah, like what are we, I mean, like I imagine we'll be wearing a mask forever. That industry is booming. Is there something else, or do you think we'll have to, like, sanitizer? Sanitizer's out of here.
Well, what I'm really hoping for is that people, this may be an impossible dream, but that people start to believe in science and scientists again. And that if you look, for example, at China, when the scientists speak, everyone stops and listens. Maybe I shouldn't use the term reverently, but I'll use the term attentively.
Right.
Because they understand this is the deal.
Right.
Praise from Joe Biden. So that's one important thing. The second important thing is the idea of social order from the perspective of our coming together for the common good, rather than just simply what's in it for me and freedom or die.
Mm-hmm.
I think those two things, the Supreme Court just said, a governor can't close churches because it's everyone's right to it's anti-freedom of religion.
What governor said?
The Supreme Court made that decision the other day when Governor Cuomo said he was closing churches down, and the new Supreme Court majority, conservative majority, and Roberts voted on the other side, said, no, you can't do that. So that to me is also a piece of the social order. So, I'm really hoping that we can come out with a degree of respect for science and a degree of respect from social altruism, I'll use rather than order, because that always sounds kind of scary. And just, a theme of my discussion is the common good and public health being finding a way so that everyone is healthy, happy, and able to reach their God-given capacity. Yeah. If COVID-19 can get us to think of those two things when we come out, as well as a stronger CDC and a way to be sure that the fire next time, if I can coin that phrase, when we potentially have something, an epidemic. I'm sort of a student of medical history. The Black Death that happened in Europe in the 1300s had 50 to 70% mortality.
Right now, everyone, just letting everyone know.
I'm sorry?
I was just saying that's not what's going on right now.
Yeah, that's right. No, this is the plague.
Uh-huh.
This is the plague, and actually, they didn't call it the Black Death at the time. That was a term put on later. But a lot of people recognize that term as the Great Plague. Had such high mortality rates and was so disruptive. I mean, that could happen again. If that were to happen, I guess people might take this more seriously. I don't know. I certainly feel, again, coming back to the term the Black Death, that a lot of people have taken it less seriously when they see that African Americans and Latinos and indigenous people are dying at higher rates than white people.
Of course.
I can't help but believe that that's not part of the story here.
Yeah. And my final question, you've seen a lot of the planet. You've had some incredible life-changing experiences. What is something, one thing that you want to tell my generation, younger generations, that we should know about what you've seen, what you've done, how we should be preparing our planet for the next generations to come? What do you want to let us know about based on everything you've seen and done?
Well, I'll let you know very quickly what our programs are about. Our programs are about doing something very simple, taking safe and effective tablets that are being donated by pharmaceutical companies out to the furthest extreme, the end of the road, the remote villages,
right,
to provide treatments to people once or twice per year to prevent these conditions. It sounds very easy. It's not. But one of the things that has struck me in this process is that, first of all, the way the Carter Center works is we don't set up parallel structures. We work through ministries of health. We work through the communities that are suffering from these conditions.
Right.
We work in these kinds of partnerships. And what's really encouraged me is communities being empowered with knowledge and with some meager resources to take the ball and do their own programs, to figure out how this should be done best in their communities, under their cultures, under their contexts.
Right.
Self-organize, volunteer, and do this for themselves, their families, their friends, and their neighbors year after year. And through that, recognize improved health in their communities as a result, and then say, okay, this was great. This worked well. What can we do next? And that idea, to give you the scope, just within where the Carter Center is working, 80,000 villages, 350,000 volunteers, and roughly 70 to 80 million treatments a year. Wow. And year after year after year. And that to me is extremely encouraging, extremely uplifting. Whenever I go and visit the villages and see how enthusiastic people are and how proud they are of what they are doing for themselves,
right?
It's really inspiring for me. So that's what I would like to leave with the audience, that people are doing this for themselves, and in doing that, figuring out that they are able to do something else and asking what that might be.
Yeah, and then also that, their overall health, really contributes to a lot of, health in a lot of different aspects, not just biological health, but, economic health and, et cetera. So that's really impactful. And we have a few questions from our audience. Dr. Richards, reflecting on your career, what would you have done differently or the same? Are you a guy that has regrets?
Well, I'm not like President Trump and say I don't have regrets.
Some people are kind of like a no regrets. Are you a regrets type of guy?
I have some regrets, but I have to say that my big regret is that we weren't at the Carter Center able to grow our malaria program as large as we've been able to grow other programs. And that was a big disappointment to me, because for the 8 years or so that I was directing the malaria program, which ended about 4 years ago, we're still working in a small area of the world. We're working on Hispaniola in Haiti and Dominican Republic. That's where our malaria programs are now.
Okay.
But we were working in Nigeria and Ethiopia. And I believe those programs, because malaria is such a lethal condition, saved more children than any of our other health programs combined. And so I was very sorry when that program ended. We weren't, we still have to find money to support our programs, and we just weren't able to.
And Jeff Bezos is worth X X X X X X X X X X X X dollars.
Right. Well, I haven't given up yet, but maybe we'll be able to get back some of that. We had an opportunity during a time when people were distributing bed nets. I think you mentioned that.
Yeah.
Insecticide bed nets to protect people from mosquito bites to transmit malaria. We did a really great job on that. It was during a period of time when everyone was talking about scale up. We need all the help from all hands on deck to help us get these bed nets out. We did our part. We got them up. But when the time came to transition to another part of that initiative, we didn't quite figure that out, or I didn't quite figure that out. I will take responsibility. So people are asking for my regrets, and that is my big regret.
Okay, so but everything else in terms of the field of study you went into, the way you went about it, the places you've traveled, the people you've been able to help, you wouldn't change those pieces.
No, I mean, from that perspective, I've been living my dream. I've been, engaged in my passion, and that all worked out. I can't complain at all.
So because nothing you're doing is easy, or paycheck driven, what, and I'll ask this in this way because this is the question that I ask all of our guests now, is what gives you wings? What wakes you up in the morning and keeps you going? How are you driven to do what you do every day?
Well, I mean, at the end, it's just the way I was built, I guess. I mean, this is what I'm into. This is like, you're sort of saying a violinist, who's able to be a violinist, a professional violinist. It's just he gets or she gets out of bed.
Yeah.
Oh my God, I get to play my violin and someone's going to pay me for it, kind of thing. So, I mean, I am lucky enough to have found a way to do what struck me back in 1977 as this is it. This is what I'm going to do.
Yeah.
Lots of people told me you shouldn't do that. It's not the way to go. You're always going to find someone who's going to tell you that, no matter how good your plan is.
Yeah.
So you have to sort of go follow your North Star. And so from my perspective, I have no complaints. I didn't make nearly as much money as I could have made in some other angles of medicine. So then I would be rich and unhappy. Now I'm doing fine and I'm happy. So as I just related, I have my regrets. Everybody is going to have their regrets and shoulda, couldas.
Yeah.
But, yeah. And I'm reading the thing, and it's not paycheck driven. I guarantee you
that. Okay. Well,
I'm sure I'm at the bottom of my medical school class earnings. That's for sure.
You think so?
If they lined us all up, yep, I'd be the bottom part.
I have my own issues with the medical field, and we talked about this before, and how one simple thing happens and your medical bill is thousands and thousands of dollars. How do we get out of that?
First of all, don't let the doctors graduate with such high loans. When you come out, of medical school, and people are, like $300,000, $400,000 in debt when they look at everything combined. Then they have another 4 or 5 years making $30,000 a year being a resident.
Right.
A lot of times people's choices are not to do what I did because they couldn't make, people would say I wouldn't be able to make enough money to pay off my loans. I was lucky. My dad was a physician and paid my way through school. So this was not something that really affected me. I understand why people are driven to cash in, but maybe we can figure out a way around that as well. A lot of people are talking about student loan forgiveness for college. They ought to think about that as well for folks who say go into medicine and elect not to be an orthopedic surgeon, but to be a pediatrician, a psychiatrist, or a public health person. The 3 Ps are the lowest remunerated specialties in medicine.
Got it. Okay.
Public health, pediatrics, and psychiatry.
Got it. Yeah, that's important because you go in, you get something simple done. It's $500 for the X-ray, if not more. Then it's this. Then you saw the person, and the consultation is $300, and then it's crazy. And so I wonder if we can ever remove the money out of medicine, to take a term that you told me when we chatted. Just for the everyman. Like how do we get to that place? And it seems like it really is in noticing the problem head on, like figuring out some sort of the educational debt, maybe.
Maybe we should pitch it to Bill Gates as one of his grand challenges. Bill and Melinda, take the money out of medicine.
Bill and Melinda, if you're watching, please take the money out of medicine.
That's right.
I'm sure it got to them. I'm sure it got to them.
As they say, make it about patients, not profits.
Yeah. We have this question will be our last question for you so I'm going to paraphrase this. So the stay-at-home order is indirectly promoting a sedentary lifestyle, which will increase the already high number of people with chronic and mental health conditions, diseases that are often preventable and frequently manageable through early detection, improved diet, exercise, and treatment therapy. Okay. How are our healthcare institutions preparing for the influx of the patients with disease? What are some of the most used tools for remote patient monitoring?
Right. So it is a long question. It's a good question. And I'm glad that this writer mentioned mental health, because mental health, along with the other, eating Cracker Jacks all day, watching TV, well, God willing, you still have a job.
Right.
A lot of people are, food insecurity is a major challenge, and mental health is a major challenge because, face it, we're social beings.
Right.
And I couldn't imagine folks who are single, don't have a partner at home, and, trying to, negotiate this, these months. And so take care of yourself, take care of your mental health.
We're trying.
There are resources out there for helplines to call. And I think one bright side on this is that the healthcare system really is trying to figure out how to do more remote patient interactions, encounters, monitoring. And if we can come out the other side, just as we've learned, we can have meetings without flying everywhere and
right.
Without my carbon footprint. You won't imagine what my carbon footprint was traveling to Africa, Latin America, Geneva, right. And now I haven't been anywhere since March. I haven't been so sedentary in my life.
Same. You've still been able to conduct business.
Yeah, I'm.
It's not as fun
from sitting in front of Zoom all the time, but on the other hand, I've been able to interact more at a certain degree. It's not the same as visiting people at their houses, meeting their families, going out to dinner.
Right.
Personal relationships aren't that easy to promote having a margarita Zoom meeting. You can kind of do it, but it's not the same.
Not fun either.
So I think we're going to have a new hybrid. We've recognized, without going through this, we wouldn't have forced ourselves to figure this out. We were forced into it. Up to now, people would say, "No, you can't do that. You can't do that."
Yeah.
And now we've discovered you can. So I'm really hoping that we will come out of this with a hybrid. But please, watch your mental health as well on this, and figure out a home exercise. I'm in the best shape I've been in years.
Really?
I've got in my garage, I've got a treadmill, I've got weights, I've got a stationary bike, and I've just put myself on a regimen. I've lost 6 pounds, and I haven't been in this kind of shape for a long time. My problem is I've got bad knees, so that's I'm never going to get back to that. But anyway, there have been some upsides that I've seen, but it's
definite upsides, and I also hope that the healthcare industry is really thinking about what this is doing and has done to those that are developing. I have a young niece, and I think about what this interaction has done for her, of the lack of interaction has done for someone that's developing their interpersonal skills, like all these things. And I'm like, wow, like are we past the point of no return? Have we ruined every 2 to 7 year old's brain?
The kids, as a pediatrician, I'm really worried about the kids. And as a pediatrician interested in the third world, we've been very, very concerned with COVID's impact on outreach programs for malaria, for immunizations, because while COVID is not really affecting kids like it is adults, if these programs collapse, an unintended consequence is increased deaths from measles, increased deaths from malaria. And I spent a lot of time worried about that. And you get into a very important part about just, the development of kids, the importance of interactions and face-to-face learning. Kids don't, a 9-year-old can't look at a screen like this.
No.
And learn. And both my wife and my oldest daughter are in education, and they feel horrified at the challenges we've got.
Yeah. Well, Dr. Richards, thank you so much for the time. This has been incredible. It wasn't that hard, was it? We did it.
Well, no, except I'm losing my voice because I've been talking so much. So
no,
I don't envy you for doing this. You do this every week?
No, not every week. We do it monthly. So this is our November one. We had an October one, and we will have a December one.
Oh, so I'm Mr. November. Good.
Yeah, you are our November, and we'll have a December one as well. And really appreciate it. Thank you so much personally for all that you're doing for impoverished people around the world. It is truly an honor to be in the presence of someone that has really seen direct impact of their efforts happen and in places where medicine and the economic machine is not really there to be able to influence in the way that healthcare would need it to be to really operate like the rest of the world. So thank you so much for doing that through your efforts and really for finding your passion and calling.
Well, I appreciate that, Royce, and I hope you share your story sometime with